Dr. Nitin Jain from MD Anderson is our speaker this evening. He's going to speak to us on how do I sequence chronic lymphocytic leukemia therapy in 2024. This webinar is brought to you by Mumbai Hematology Group. It is supported by Ceylon Lab and it is managed by Perfect Square. I thank Debabrata Chakrabarti, Swayambhu Mandal and the team from Ceylon, Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, of course, our guest speaker, Dr. Nitin Jain from MD Anderson. All our discussants were themselves eminent hematologists or medical oncologists. You participants for sparing your Saturday evening or morning or afternoon, depending upon which part of the world you belong to. We have registrations for almost 30 countries today. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have Dr. Vidisha Mahajan from PD Hinduja Hospital, Mumbai, speaking to us on platelet puzzle, why precision in testing matters. Our discussants today are very good personalities from all across the country. Very briefly, Dr. Akanksha Garg from Ahmedabad, Dr. Ami Patel from Surat, Dr. Amit Khurana from Surat, Dr. Ankit Jitani from Ahmedabad, Dr. Ankit Rayani from Ahmedabad, Dr. Anushri Chaturvedi from Varanasi, Dr. Bharat Parikh from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. Deep Gala from Lucknow, Dr. Fahima Hassan from Prayagraj, Dr. Kripa Bajaj from Hyderabad, Dr. Kunal Goyal from Mumbai, Dr. Khushbu Jain from Aurangabad, Dr. Mona Vijayan from Lucknow, Dr. Nitin Gupta from Delhi, Colonel Dr. P. Suresh from Delhi, Dr. Prateep Reddy from Chandigarh, Dr. Pritesh Junagade from Nashik, Dr. Rajan Yadav from Ahmedabad, Dr. Rizwan Akhtar from Lucknow, Dr. Saroj Bala from Raipur, Dr. Sailesh Lavana from Vadodara, Dr. Siddharth Kalantri from Nashik, Dr. Sudarshan Pandit from Nashik, Dr. Vikas Talreja from Kanpur, and Dr. Yashwant Kashyap from Raipur. Dr. Nitin Jain does not require any introduction to the audience today. He is a huge name in the field of chronic lymphocytic leukemia. He has been helping us for last almost a decade in learning from A to Z of this particular disease. Whatever we know today and whatever little we know today, it's all courtesy Dr. Nitin Jain. He has come all the way to Mumbai and India to teach us about the advances in CLL, and he's also conducted a lot of webinars for us to update us after each major meeting in this field. Just for those who are new, and there are a lot of students who are with us today from India and across the world, Dr. Nitin Jain is Professor, Department of Leukemia, University of Texas, MD Anderson Cancer Center, Houston, Texas. He earned his medical degree from AIIMS Delhi almost 22 years ago, that is 2002. He completed internal medicine residency at the Medical College of Wisconsin. He then completed clinical fellowship in leukemia at MD Anderson itself, followed by leukemia research fellowship at Memorial Sloan. He pursued fellowship in hematology oncology at the University of Chicago. He joined as a faculty in the Department of Leukemia in MD Anderson in 2012. He treats patients with acute and chronic leukemia, and his focus is on chronic lymphocytic leukemia and acute lymphoblastic leukemia. His research interests include new drug development in patients of these two disorders. Since 2021, he has also served as Director, Leukemia CAR-T Program within the Department of Leukemia at MD Anderson. He is principal investigator of several investigator-initiated phase 1-2 clinical trials, including combination targeted therapy, Ibru with Ven in CLL, checkpoint inhibitor for Richter transformation, JAK2 inhibitor ruxolitinib for PH like ALL, novel CD22 antibody drug conjugate for B-ALL, venetoclax plus chemotherapy in B and T-ALL, ponatinib in T-ALL, and off-the-shelf allogenic CAR in B-ALL. The trial combining Ibru and Ven was published in New England Journal of Medicine in 2019. He has published papers in prominent journals including NEJM, JCO, Blood, Clinical Cancer Research, Cancer, Leukemia and Lymphoma, Leukemia Research, and others. He has won several awards during his career, including Sardari Lal Kalra Gold Medal in Microbiology at AIIMS and Merit Award from the American Society of Clinical Oncology. The trial combining Ibru and Ven was published, as I mentioned, in NEJM in 2019. He received High Impact Clinical Research Support Award from MD Anderson Cancer Center in the year 2014 and 2016. He has served as faculty on American Society of Hematology CRTI workshop from 2017 to 2019. He is recipient of Sabin Family Foundation Award in 2018. In 2020, he received MD Anderson Faculty Scholar Award. In 2021, he was appointed director of the CAR-T, as mentioned earlier. In 2022, he received Leukemia and Lymphoma Society Scholar in Clinical Research Award, as well as LLS Translational Research Program Award. He will be speaking to us how to sequence CLL therapy in 2024, a subject that we are often confused. Thank you so much. And I hand over the reins now to Dr. Nitin Jain.
So first of all, thank you, Dr. Agarwal, for this kind introduction. So it's always fun to talk to this group and always fun to give a talk like this. I think it's very helpful and enjoyable. So I think you can see my screen, maybe.
Yes.
Can you see the screen?
Perfect.
Okay. Yeah. All right. So my goal today is to talk to you about the CLL therapy in 2024. I've kind of break up the talk in the first line therapy and then relapse therapy. Obviously, sequencing. For sequencing, you need to know what's the data with the first line therapy and then what's coming out of the second line therapy. So I'm kind of overview the CLL therapy with updates from ASH 2023 and kind of how we are looking at the field. So these are my disclosure. Let me get it as well. So just before I start, I think, and it's important to realize that today, not today, but this year is a decade, 10 years of approval of oral target therapy in the context of CLL. So you originally, ibrutinib was approved in the US for CLL on February 12, 2014. So just about 10 years ago. So that was really a big pivot in terms of the CLL therapy as we started moving away from, chemotherapy such as FCR to oral target therapy. So ibrutinib was 10 years ago, and now we have multiple agents approved. So this is the story. As I mentioned, 2014 was ibrutinib. Then we have other BTK inhibitors, namely acalabrutinib. We have PI3 kinase inhibitors, BCL2 inhibitor, as well as novel CD20 antibodies such as obinutuzumab. And then more recently, just last year in the US, zanubrutinib was approved, which is another covalent BTK inhibitor. And importantly, pirtobrutinib was approved in December of last year for CLL, which is a non-covalent BTK inhibitor. And then I was telling Dr. Agarwal just before the meeting started that just a couple of days ago, 2 days ago, I had to update this slide because the CD19 CAR-T called Lysocell, which is made by Bristol Myers Squibb, was approved for CLL in the United States. So that's the first CAR-T approved for CLL because all the previous approvals for CD19 were for DLBCL and mantle cell and others, but never for CLL. So that's 2024. And then I think going down the line, there are other agents in development. There are CD20 bispecifics in development. There are some novel BCL2, right? We already talked about venetoclax, but there's no more. Could there be another venetoclax-like drug? So there are a couple of them in phase 3 trials in CLL right now, actually. And then BTK PROTACs is a new field where these are oral drugs, which basically not just degrade the BTK completely. And there are ongoing phase 1 studies with many of the companies working in this space with BTK PROTACs. So as you can see, we have a lot of impressive approvals already and some coming down the line. So in terms of the first line CLL, and again, just to kind of make a preface, I think we have moved away from chemotherapy. So I'm not really going to show any chemotherapy data, but happy to talk about that. but this is really the field has moved to target therapies. At MD Anderson, we're not using any chemotherapy at all. Everything is target therapies for our patients. So there are three options, which are indefinite therapy, continuous daily drug, ibrutinib, acalabrutinib, which can be used with obinutuzumab, or zanubrutinib. I know at least the first two are available in India. I don't think zanubrutinib is available in India. And then we have the time-limited approach, which is with venetoclax plus obinutuzumab, and also venetoclax plus ibrutinib, which is approved in Europe and many other countries in the world, but it's not approved in the United States. So those are the two time-limited approaches for patients with CLL. So just as a brief background, again, for trainees or who are fellows who are listening, ibrutinib was first approved in the frontline therapy based on this trial, which randomized patients to ibrutinib versus chlorambucil. And not a surprise here, you can see at 7 years with ibrutinib, about 60% of the patients were progression-free. So remember this number, 7 years, 60% were progression-free. Obviously, chlorambucil is not doing that well, as you can see the curves. So no question, ibrutinib is a clear winner here in terms of progression-free survival. Now, ibrutinib is a first-generation BTK inhibitor. So then the concept arose, and then there are some toxicities associated with ibrutinib if you have used it in your clinical practice. So then Acala and Zanu are the second-generation BTK inhibitor, which works on the same target. They are covalent inhibitor. They bind to cysteine 481S, a residue of BTK, but they have less off-target effects, and presumably that's leading to less toxicities. So acalabrutinib is a second-generation BTK inhibitor, which now second-generation have become the preferred BTK inhibitor in the US. We're really not using ibrutinib anymore. Everyone is using second-generation inhibitors, could be acala or zanubrutinib. So the data with acalabrutinib in the frontline therapy comes from this ELEVATE-TN study, which was updated at this past ASH meeting with a 6-year follow-up. So this is a study which, again, older patients were given acala-obin, acala alone, and chlorambucil-obin. So here, the difference is that you have two arms where acala alone is being also, you have a randomization to acala plus obin. And what did they see? And this is the data from ASH. Obviously, chlorambucil-obin is not doing well. Acala alone, 6-year is 62%. You may recall I showed you a few slides before with ibrutinib, with a caveat of cross-trial comparison at 7-year was 59%. So it looks like acala single agent is in the same ballpark as ibrutinib single agent in these two studies, about 60% at 6 to 7 years. But then acala obin arm, to I think everyone's surprise, has been doing remarkably much better, 78% PFS versus 62%. And the only difference between these two arms, because both groups are continuing acalabrutinib, this group received early on in the first 6 months right here, obinutuzumab. And that has improved the PFS versus acalabrutinib alone. So most of us didn't think that would be the case. We thought that because both groups are continuing acalabrutinib, the PFS curves will kind of, be very close to each other. But it looks like that's not the case, and these curves continue to kind of separate out. So this kind of make a stronger case that, hey, if you're going to use acala, maybe add with obinutuzumab. I know it's quite expensive in India, so we don't know what acala rituxan would do, in all fairness, but at least the data is with obinutuzumab. And notably also, the OS was numerically higher as well, not statistically improved, but just certainly kind of goes to show that I think this acala-obin can be a quite powerful regimen. Here, they also showed that acala-obin versus chlorambucil-obin, there was an OS advantage. So certainly, I think we are not using chlorambucil in the US. It has been, for quite some time, but certainly one of the trials now, which is also showing in the target therapy era, survival advantage of acala-obin versus chlorambucil-obin. So certainly, I think a very appropriate and effective regimen is acalabrutinib, and combining with obinutuzumab can improve the PFS. Now, and the similar data is with zanubrutinib, which I'm not showing in the interest of time. So we have 3 BTK inhibitors approved in the frontline setting: ibrutinib, acalabrutinib, zanubrutinib. All are showing PFS. Some are also showing OS advantage over chemotherapy. The problem here is that these therapies are indefinite. You have to keep taking a BTK inhibitor every day, and it adds to the cost, and especially in Indian context, many patients may not be able to obviously afford it. So then came this option of time-limited therapy, which again, really, I think have revolutionized the field in a way of the treatment, because we are now be able to deliver time-limited approach for our patients, and with quite positive results, which I will show in 1 second. So this is a trial which have been reported for many years. This is ven-obin versus chlorambucil-obin. And then this is from the EHA last year. This was not updated at ASH, but the EHA, what they showed is a 6-year PFS is about 53%. And these are my additions to the slide, 6-year PFS of 53%. So here you can, now if you recall back, I showed you before, with ibrutinib and with acalabrutinib, not the median, but the 6-7 year PFS was close to 60%. So this is in the similar ballpark, but the major difference is here the treatment is only for 1 year. That's it. Rest of the time is treatment-free interval. So that makes a kind of a strong case, and you potentially can retreat these patients and get a second, progression-free survival to say, because these patients will respond when you retreat them with venetoclax again. Now, the story with IGHV mutation is evolving. So as you may know, with FCR, with chemotherapy, IGHV mutation matters. If you're IGHV mutated, you do better. Unmutated, you do less well. When ibrutinib came along, or the results with ibrutinib generally tends to state that IGHV status doesn't matter. But when we are looking at now longer-term follow-up of ven-obinutuzumab, and I think any time-limited approach you take, if you stop therapy and then you follow these patients in a treatment-free interval, IGHV mutated patients will do better than unmutated because the cells cycle slower and they will, remain in remission longer time in the treatment-free interval. And that's what we saw here. For 6-year PFS with mutated is very nice at 70%, but for 6 years at unmutated is approximately 43%. Doesn't say that we should not use ven-obinutuzumab for unmutated, because again, you're getting quite a decent treatment-free interval, and then you can, at this time when you relapse, you potentially can use a BTK inhibitor at that time or try to retreat with venetoclax. One group it does not really matter that much is del-17p53, where in this analysis, again, the 6-year PFS is quite dismal at about 20%. So as I mentioned to you, we have now 3 approved agents in the United States for the frontline therapy: ibrutinib, acalabrutinib, and zanubrutinib also, and then ven-obinutuzumab. And there are pros and cons of these approaches. Ibrutinib is the solid, it's the first approved drug. I showed you 10 years ago was approved, has the longest follow-up. Many more patients in the world have been treated with ibrutinib. But again, these side effects, atrial fibrillation, bleeding, hypertension, arthralgias, those can be quite problematic for some patients. Acala and Zanu certainly have the same thing, that they are daily continuous therapy, but they have a lower rate of off-target effects. And when obinutuzumab, I think the beauty here is that it's a 1-year therapy, high rates of MRD, negative remissions. The downside here is that you have to monitor for tumor lysis syndrome. I think if you follow the guidelines, you give the hydration, you give allopurinol, all those usual stuff, you have to manage tumor lysis syndrome or prevent tumor lysis syndrome. No patient really gets into tumor lysis syndrome, but you have to just manage that. And that could be a logistics part of PLS. Obin is infusion, so that adds to the infusion and the cost. Grade 0 for neutropenia is seen in about 50% of patients in this regimen, so you have to be aware of it. Though neutropenic fever is actually quite rare. So you give them growth factor, GCSF, and the ANC comes up, then you can restart venetoclax at a lower dose, depending on how low the counts went. And then, as I mentioned, P53, they don't do that well with this regimen. So 3 or 4, in a way, fantastic regimens we have available. As I mentioned to you, ibrutinib has fallen out of favor in the United States. So really the discussion in the clinic, when a patient is not going to clinical trial, I present to them these 3 options: acalabrutinib, zanubrutinib, which are, in my opinion, very similar regimens, and then ven-obinutuzumab, which is a 1-year regimen, and then let the patient make a decision unless there is a there is a reason from a clinical standpoint that you would favor one. For example, if patient has deletion 17p53, I may favor this regimen with the BTK inhibitor. If a patient has significantly large lymph nodes, they have a 15 centimeter intra-abdominal mass, their creatinine is 2.2. Using a venobin may be a bit tricky in terms of tumor lysis risk. And in that situation, I may consider this as well, Acala or Zanu. On the flip side, if a patient is on atrial fibrillation, is on anticoagulation, has a recent heart attack, I may be just concerned about more cardiac issues, AFib issues with BTK inhibitors, and I may consider when obinutuzumab. But those are some of the things you can think about in terms of choices of treatment. So how the field is moving is that we talked about this ibrutinib single agent, or we talked about obinutuzumab, but really the field is trying to move towards these double oral therapy, BTK plus BCL2, combining ibrutinib with venetoclax, or combining another BTK inhibitor with venetoclax, or triplet. Why not use all three best drugs together upfront? And I will show you very briefly about some of the concepts. So at the ASH meeting, there were several presentations about ibrutinib plus venetoclax, and I wanted to go through that because they were, I think, quite informative. So first, I wanted to highlight our work. We updated this 5-year update of the trial we have been doing for several years at MD Anderson, combining ibrutinib plus venetoclax. This was a trial we started back in 2016, actually. So previously, this work we had previously published in New England Journal and then in JAMA. And now at the ASH meeting, we were reporting data for a total of 120 patients with a median follow-up of 5.5 years. Now, this trial, when we designed this trial, we designed this trial for frontline high-risk genetic patients. So as you can see, the genomics are listed here. We did allow patients above 65 years to enroll without having one of the genomics, but that constituted only a small minority of patients. Now, an important aspect of this regimen is that everyone got 2 years of therapy. There was no 1 year of therapy. Even if you're MRD negative at 1 year, you got 2 years of therapy. So by default, everyone gets 2 years of therapy. And there was a provision that MRD positive patients by flow at 2 years of therapy get a third year. But everyone by default get 2 years of therapy. And I'm emphasizing that point for a reason. I will come back to that after a few slides. So this trial was, one of the largest trials for single agent, single institution investigator-initiated trial. We enrolled actually a total of 200 patients on this trial. 80 were relapse refractory and 120 were frontline. You can see because we purposefully selected for high-risk genomics, 86% of these patients were unmutated, which is actually a very high number of patients being unmutated V gene. We followed these patients serially, 3 months of ibrutinib, then we added venetoclax for a total of 2 years of combined therapy. And we actually, in this trial, we did several bone marrows during the study to monitor for response. And at 1 year, 52% of the patients were flow cytometry MRD negative, and overall 72% were flow cytometry MRD negative, which is actually quite high rates of bone marrow MRD negative remission with 2 oral drugs. And this is the 5-year PFS. If you look at the 5-year PFS, is around 90%. The 5-year OS also looks quite well. And then if you look at by P53 or IGHV status, didn't really matter. Both were equally kind of working well. Again, the number of P53 is only 27 patients, and the number of IGHV mutated is only 16 patients because, as I mentioned before, we purposely selected for unmutated V gene patients. So this was a single center MD Anderson study, which we had reported before, and this was kind of a 5-year update. But one of a big presentation at ASH, which was subsequently reported in New England Journal on the same day, was ibrutinib plus venetoclax versus FCR. And this was presented from the UK group. So this is an ongoing study for 4 different arms on this randomized design. And this study originally started with FCR versus ibrutinib rituximab, but then later they added 2 more randomization arms in 2017, it looks like. And now for the first time, we were hearing results of FCR versus ibrutinib plus venetoclax in terms of randomization. So FCR is kind of standard But here, one of the important factors is that the duration of ibrutinib plus venetoclax was a bit long. It was from 2 to 6 years. So it's not like 1 year of therapy. It's not like 2 years of therapy at what we gave at MD Anderson practically for most patients. This was a much more prolonged therapy for 2 to 6 years. And how they decide on 2 to 6 years is, and they have this hypothesis that the time it takes to become MRD 0 or MRD negative by flow cytometry, which is 10 to the power minus 4, if you double that duration, then that possibly will lead to the most optimal disease control long term. And this has their mathematical modeling, which kind of shows that basically what they're trying to show is that if you become MRD 10 to the power minus 4 at 1 year, you do 2 years of therapy, and presumably that will lead to 0 disease. If you become at 2 years, so basically you double the duration. If you had 2 years negative, then you take 4 years of therapy. If you're negative at 3 years, you take 6 years of therapy. So it could be 2 to 6 years, depending on when you became MRD negative, and then you double that duration. So it's a lot of two drugs together. Again, the same thing I kind of showed you is showing here. They treated a large number of patients. And this was, I think, very important, that at 2 years of therapy, at 2 years time point, about 50% were MRD negative, and they were able to stop it. And then you can see over time, more number of patients are able to stop it. But practically, you can see everyone got 2 years of therapy. And then obviously some patients are still continuing therapy beyond 2 years per study design. And this was the reason this paper made it to New England Journal, was this PFS curve. So this is ibrutinib plus venetoclax, and this is FCR. So obviously, FCR has been the standard treatment previously for younger patients with CLL. And here, for the first time, we are seeing such a remarkable difference. And look at the PFS at 3 years, 97%. And this is not a single center study. This is a phase 3 multi-institutional study, which is, kind of a gold standard. So it was very nice to see such high rates of PFS, which is mirrors what we reported at MD Anderson at a single center study. And not that, they also show improved overall survival for these patients. So again, really making a point that we should not be using chemoimmunotherapy for our patients. These new drugs, and especially now with ibrutinib plus venetoclax, really impressive PFS and OS. Now, sometimes a question arises, they may have the chemotherapy arm may not have received targeted therapy afterwards, and that's why the survival benefit was seen. So they specifically did report that the patients who progressed on FCR, they received irreversible BTK, which is basically Acala or Zanu or ibrutinib. So most of the patients were able to receive targeted therapy at the time of relapse, but still we were seeing this OS advantage. And then one of the concerns with use of ibrutinib has been cardiac side effects. And at least in this analysis, they didn't really see that much. They did, however, see some deaths from MDS-AML after FCR, which again is a known complication of chemoimmunotherapy. So overall, I think this study really brings point out that, first of all, we should not be using chemotherapy. And secondly, ibrutinib plus venetoclax can be quite effective. Again, this study used 2 to 6 years of therapy, not 1 year of therapy. Now, there's another study, Captivate study, which has been going on for a large time in the US. It's a phase 2 study, not US and UK, US and Europe. And they have used 1 year of therapy for doublet. So Emerson study 2 years of therapy, Flare study 2 to 6 years of therapy, and this Captivate study, they used 1 year of therapy. The purpose of this abstract was to show basically, and which comes up quite often, is that if you're going to use your best drugs up front, both BTK and VEN, then what are you going to do at the time of relapse? And what happens is at the time of relapse, because the relapse practically happens in the off therapy phase, no one really relapses when they're getting these drugs. And when you check for these mutations, at the time of relapse, no patient has this mutation. And the patients are sensitive to reinitiation of therapy with BTK or BCL2 or together. So that was the main purpose of the abstract. What the authors also reported at the same time was they reported a 4.5 year PFS with this 1 year combination. And you can see here for a 4.5-year PFS was dropped to 70%, and for deletion 17p was dropped to 45%. So that numerically is inferior to what we reported from MD Anderson and also what the FLAIR study from the UK reported. And I think in my mind, and this is a summary slide I made, one of the major differences between these three regimens and why maybe Captivate has a lower PFS than versus MD Anderson and the FLAIR study is the duration of therapy. It's 2 years for MD Anderson by default for everyone. It's 2 to 6 years for FLAIR and only 12 cycles for Captivate. And I would argue that maybe 12 cycles is not the appropriate duration, and I think we need to treat these patients with this regimen for a longer term. But what is that ideal duration, whether it's 2-year flat for everyone, or we do something what the UK group did? I think that remains to be seen. Now, another important trial. So this was all basically, what I showed you, several trials with ibrutinib plus venetoclax. Now, another major trial which was updated at ASH was bringing really venetoclax in the front line with the antibody therapy. And this is what the CLL 13 study is, which is chemo versus Ven-R. And this is a question which comes up quite often. Obinutuzumab, and again, I think in Indian context is very expensive, may not be easily available. So why can't we just replace with Rituxan? But this trial did that. They did Ven-R, Ven-G, so G is obinutuzumab, and they also did a triplet of ibrutinib, Ven, and G. There was no ibrutinib plus venetoclax here. That would have been quite nice to have. And what they showed, and this is an updated 4-year data, is that the top curve is Ven, ibrutinib, obinutuzumab, so the triplet. The second curve is Ven, obin. The green curve is Ven Rituxan, and then the FC chemotherapy curve is the blue one. So as you can see, Ven Rituxan is actually not underperforming, is inferior to Ven obinutuzumab. So certainly this will make a case that we should be using obinutuzumab for maximum benefit for patients with CLL. And certainly the triplet, whether triplet is better than the doublet, I think that kind of remains to be seen. OS, there was no improvement in this study. And I mentioned to you, obviously we have many different BTK inhibitors, and I think you guys are using maybe acalabrutinib is available quite commonly in India. Many people are using acalabrutinib these days. But venetoclax is the only BCL2 inhibitor. But what about some other maybe BCL2 inhibitors? And there are 2 such drugs which are in phase 3 trials right now. One where we have a lot more data is sonrotoclax, which is also called with a company called BeiGene. So what is sonrotoclax? For the investigators, it is much more potent than venetoclax, and it does work against BCL2 resistant mutations, especially G101V, which has been present in some patients who fail venetoclax for CLL. And they also report that this drug sonrotoclax is actually only short half-life of 4 hours as compared to venetoclax, which is slightly longer. And their argument here is that because of the short half-life, this drug does not accumulate over time, and maybe versus venetoclax, and where there will be less myelosuppression with this drug. So this is early data. They have treated about 107 patients. These are frontline patients. They're compared with sonrotoclax plus Zanu. So basically, we talk about ibrutinib plus venetoclax. Here's Zanu plus sonrotoclax. So again, the concept is the same, a BTK inhibitor and a BCL2 inhibitor, but you have zanubrutinib as a BTK inhibitor, and you have sonrotoclax as a BCL2 inhibitor. With this study, they, again, with a short follow-up, they haven't really seen any tumor lysis syndrome, no atrial fibrillation. Overall, the regimen seems to be well tolerated. Emerging data, but again, the high rates of MRD, which again, we would expect with these kind of drugs. So I think this is a drug which is now moving to phase 3 study, this regimen. And this is actually exactly my next slide. So in the frontline setting, in the US, or not just the US, everywhere, I guess, many trials are being done comparing different backbones to investigational arms. And then you can also see that very few are using chemotherapy anymore. I mean, this is an older trial. So this first trial, FCR versus BR, was started several years ago. But you can see the control arm for many of the new versions of the trials are with ven obinutuzumab. And then there are several investigational arms which are being pursued. I just want to highlight maybe a few trials here. So this trial, the first trial on the list, is expected to be reported out later this year. This is chemo versus acalaven versus acalaven obinutuzumab. And I'm really waiting for this trial because I think if this trial is positive, this may lead to approval of acalaven with and without obinutuzumab, depending on how the obin arm does for patients with CLL. Then you have the CLL17 trial, which is randomizing continuous ibrutinib versus Vengi versus venibrutinib. So again, three important regimens to think about. MAGIC studies using Vengi versus acalaven. So two time-limited one-year approaches. And then you also see down here trials with pirtobrutinib. For example, this trial is randomizing ibrutinib versus pirto. So head-to-head ibrutinib versus pirto. And the last one I recently added to this table is the Vengi versus sonrotoclax plus Zanu. I showed you this, data with this sonrotoclax. And so this is a head-to-head comparison with Vengi. And again, if this trial is positive, that will lead to approval of Zanu plus sonrotoclax in frontline CLL. So this is kind of a second generation of BCL2 inhibitors coming in a phase 3 study as well. And these yellow highlights really shows all the regimens which are time limited. So what you can see here is that, first of all, Vengi is being used as a comparator arm for many of the trials. And then a lot of trials, the experimental arm is actually time limited. So we are really moving away from continuous daily drugs and to these time limited approaches. At MD Anderson, we have been doing a trial, just maybe a plug for our trial here, using pirto in the frontline setting, pirto ven obin. And we will be reporting the first clinical data at ASCO and EHA meeting in a few months. So, we look forward to presenting the data with this new triplet in CLL. Now, what about relapse CLL? And in some sense, the topic given to me was sequencing. So the sequencing, you have to know the first line therapy, and then you can think about sequencing. And this is a very interesting kind of a scenario we are in the context of CLL. So think about sequencing, and sequencing scenarios in the context of CLL is depending on how you start treatment. For example, the most common scenario these days is that you start with a covalent BTK inhibitor, such as ibrutinib, acala, or Zanu. You get maybe a 7-8 year remission. Patient progresses. Then you add a venetoclax plus rituxan or venetoclax plus obin. You have to give it for 2 years, and then you stop therapy because that's what the guideline is. Then you have this treatment-free interval. Patient relapses 3-4 years later. Then you can start a non-covalent BTK inhibitor, which will be a drug such as pirtobrutinib. You can reuse venetoclax again, or you can go to some investigational approaches like CAR-T or other approaches. So that's I think, a common scenario in practice. But what about if you start with ven-obin first? You can do ven-obin, get 6-7 year treatment-free remission, then start a BTK inhibitor, then you get several years again, and then you look at other therapies, non-covalent BTK and others. Or in choice C, you start with ven-obin, then you start again with ven-obin when the patient relapses. And when the third time the patient relapses, then you're moving to a covalent BTK inhibitor. Or the fourth choice, where you're starting with a covalent BTK inhibitor, for example, acala, 7-8 years later, patient progresses, and you right away switch the patient to pirtobrutinib. And you reserve your BCL2 for the third lines of therapy. And there could be other scenarios you could envision, obviously scenarios combining ibrutinib plus venetoclax, in the frontline setting as well. So I think the important point here is that if you look at the y-axis, x-axis is going so 15 plus years. So patients are really living longer, which is fantastic. And I think that just shows how much progress we have made in the last 10 years with this disease, that now in terms of the sequencing, if you were to say, okay, what is the sequencing scenario? I want to design a randomized trial. Really, it's just not a practical thing to do because you have to wait 10, 15 years for the readout. And by that time, the field would have moved on to, some other new generation of a BTK inhibitor, and the trial you're doing, it will be really clinically not much meaningful. So I wanted to show some of the data slides before we finish in the relapse refractory space. And one of the important points to highlight will be, and some of these data are not from ASH meeting, but they are important, is that there are two randomized studies which have been done comparing BTK inhibitor ibrutinib with the second generation BTK inhibitor. This is so-called Elevate RR trial, where for relapsed patients, Acala was combined head-to-head with ibrutinib. Efficacy was the same. But then there was another parallel trial called Alpine trial. I should mention, I guess in this trial, I think the slide I didn't include. The efficacy was the same, but the safety was better with acalabrutinib versus ibrutinib. A slightly similar trial, but some design changes, but in the relapsed refractory setting was the so-called Alpine trial, which compared Zanu versus ibrutinib. And the initial report the previous year showed a median follow-up of about 30 months, where Zanu was compared to ibrutinib. And one of the criticism here was, oh, the follow-up is short. So the investigators did update the data, and this is from the ASH meeting, where similar follow-up for the Elevate study with acalabrutinib, still the PFS advantage continues to be maintained for Zanu versus ibrutinib. I should say that in terms of the safety, again, Zanu is less atrial fibrillation than ibrutinib. So I think, in my mind, both the drugs are certainly safer than ibrutinib. Whether zanubrutinib, at least the data will suggest, is better than ibrutinib, I think the data will suggest that. But does that mean that zanubrutinib is better than acalabrutinib? I don't think we can make that jump. So in my mind, both drugs are very, very effective, and I kind of use them not interchangeably, but I don't think there's one to be preferred over the other in terms of the second generation BTK inhibitor. Now, a new addition to the field of CLL for the last few years have been pirtobrutinib, and this drug was officially approved for CLL in December of last year. So this is, you will say, okay, how many ibrutinibs we need, how many BTK inhibitors we need. But you have to realize this drug is a different drug. This drug is not your straightforward covalent BTK inhibitor. This is a non-covalent BTK inhibitor, but that makes a lot of difference. That this drug can work for patients who have failed ibrutinib, failed acalabrutinib, failed zanubrutinib. And this drug also appears to have very limited side effects. It's very selective for BTK. This basically shows here, this is very selective for BTK. And this drug works, it doesn't bind to the cysteine 481S residue. It just sits in the pocket and blocks the interactions, so that it turns out to be a very effective drug for patients who have failed prior ibrutinib. Now, this data we have seen before. This is an update from ASH, but message is the same. That for patients who have progressed on ibrutinib or acala or Zanu, many of them have also progressed on venetoclax. This drug works very well. As you can see, practically everyone, the lymph nodes go down quite remarkably with single agent pirto. But the issue has been that look at the median PFS. It's about 19 months. Now, it is guaranteed these are very heavily pretreated patients, 3 prior lines of therapy. So, but again, everyone eventually will relapse. Very few patients are going beyond 3 years in remission. So, tells me that yes, pirto is a good drug to stabilize the condition, but it's not going to be a cure. So I think you have to, when you're starting a patient on pirto, and again, I don't know what the introduction plans are for pirto in India, when Lilly is going to get it in India, but or some other company. But I think it's a fantastic drug, and I think if you use in early lines of therapy, it can be quite powerful drug. But certainly these double refractory patients, it can work very well. Now, one thing which is emerging in the field, and I wanted to just bring it out to you guys, is this resistance mutation. So you may have heard about cysteine 481S mutation, because that's now well-described resistance mutation to ibrutinib and acalabrutinib and zanubrutinib. But now that we have these new drugs like pirtobrutinib, which does not bind to cysteine 481S, what we are starting to see, and this is a data where they looked at patients who have failed pirtobrutinib, and then they saw that about half of these patients develop BTK mutations, but these are not your usual cysteine 481S. These are 474I, L528W, and others. So there are these new mutations of BTK which are not previously described, which are now being detected in these patients. And I think it's similar to, you can think of the CML field in a way, where obviously, T315I, you use ponatinib, and there are other mutations which we have different sensitivities to different TKIs. I think that kind of a story will evolve, may evolve in the context of CLL as well, because some of these resistance mutation, for example, there is some data that L528W can occur after zanubrutinib. So if you're a patient on zanubrutinib who develops L528W at the time of resistance, then you cannot use pirto because it will likely won't work. For example, some data that T474I can occur after acalabrutinib. So again, then zanubrutinib will, then pirtobrutinib won't work. So you may need to know the mutation before you are selecting pirtobrutinib. Doesn't matter if you're going to start with venetoclax, then it doesn't matter in a way. But to switch to a different BTK, you may want to know that. So I think that field will evolve as we generate more data in this regard. In the next maybe couple of abstracts before we close and maybe open up for questions. So there are other exciting stuff which is coming on. I mean, already so many different drugs and targets. But these BTK inhibitors, there's a new class of drug called BTK degrader. And what is a BTK degrader? So it's more like, like from the myeloma field, where this is a slide by a company called Neurex, where this basically, this compounds through cerebral mediation binds to BTK, and then proteasome degrades the BTK completely. So basically, this is complete BTK is degraded. So basically, the assumption is that it doesn't matter what mutations or what's present, because the entire BTK protein will be tagged, and then ubiquitinated, and then will be destroyed or by the proteasome mechanism. So this is a new class of drugs, and I can tell you there are like 3 or 4 different companies which already have ongoing trials with these drugs. These are oral drugs. I just want to show you a brief snippet of a clinical trial data. There's an ongoing trial with this BTK degrader. Only 7 patients with CLL have been treated. So, I mean, that's a small number of patients, but other disease histologies have been treated. But again, with a caveat, a small number of patients, you can see these patients are responding. So early data, and I think by this next ASH, I think we'll have much more data. But I think be ready. I think this is a new field of class of drugs, BTK degraders, which will, I think, come big time in the field, and it's an oral drug in the field of CLL. And my last maybe slide deck is about lysocell CAR-T. So I mentioned to you at the start of the talk that CAR-T 2 days ago, March 14th, CAR-T was approved in the US for CLL, and that this was the trial, and this is the data. So this is called lysocell, which is made by Bristol Myers Squibb, BMS, and they based on this data, FDA approved it a couple of days ago. And Dr. Agarwal was asking me, so this is a 24-hour, 2-year update of the data. So here, again, standard lymphodepletion, as you know about CAR-T now, and the approved dose is 100 million cells, flat dose. So basically, it's about 1 to 1.5 million per kilogram, depending on the size of the individual. So they had 118 patients overall, and then out of which 71 patients, what they called were double refractory. So they had failed BTK and they had failed venetoclax. An important line here is 5 prior lines of therapy. So these are heavily kind of pre-treated patients. Now this is just want to focus on this side. So the CR rate, which was their primary endpoint, was actually not very high. It's only 20%. And then another 24%, I guess, the total overall response rate was about 44%. And then the MRD rates were slightly higher at about 60%. So numerically, if you look at this data, and I'm sure you have looked at other lymphoma data and BALL data with CAR-T, numerically, I mean, I think it looks a bit inferior, where your MRD rates is about 60%, and your overall response rate, which includes both CR and PR, is about 44%. So, and that also is reflected here. When you look at the PFS for the entire study population is what, 18 months. And if you look at this double refractory, which is where you will use this drug, right? Patients who have failed ibrutinib, failed venetoclax, is about 1 year. So I think this is a great addition, but I think you have to be prepared that there are very few patients who are going beyond 2 years with this drug at this time. So I think that's something will have to be. Now, they do make a point that if you were to achieve a CR and this NR is actually not reached, it's kind of looks no response, but it's not reached. Patients who achieve a CR, and they had 10 patients, out of the 50 patients, 10 achieved CR. They are doing well, but the rest of the group are not doing that well. So I think that's something, maybe a slightly longer follow-up will help us, but at the same time, I think there will be a tail to the curve. I think that remains to be seen. So I guess in my last slide, I think maybe I relate to you, the current data with BTK inhibitors in the frontline setting, which are approved, BCL2, CD20 antibody, which is approved as well. I think this concept of BCL2 BTK, ibrutinib and acalabrutinib, I think it will come along. It's already approved in EU and other countries, not in the US. Whether you need a triplet, I think I showed you a slide with many randomized trials. I think only randomized trial can help us, because both these doublet or triplet are so effective. It's very difficult to tease out the differences when you have 80-90% MRD negative remission rate. For the relapse CLL, I think the treatment choice really depends on the prior therapy patient has received, right? If a patient has, and I showed you a figure where different sequencing scenario you could entertain. I think non-covalent BTK inhibitors, namely pirtobrutinib, looks quite promising, and I'm looking forward to early lines of their data. CAR T-cell therapy, just got approved in the United States, so I think more patients will get treated now, and I think it's a great advance to the field, and I think certainly, hopefully, more companies will come into fray to develop maybe better CAR Ts. And I think many novel targets are being studied. We talked about some of them already. I did not talk about Richter's transformation in the interest of time, but again, that remains an unmet medical need. We and others have looked at checkpoint inhibitors, pirtobrutinib, venetoclax, CAR T. So I think, but still, I think we're not making much headway. I think we're making some positive development, but I think curative strategy really remains stem cell transplant, which for many of these patients remains a bit of a challenge given their age and comorbidities and whatnot. So with this, thank you for your time and attention. I hope you got some new information and ready to take questions. Thank you.
Thank you so much, Dr. Nitin, for updating us. This was a beautiful presentation of what has happened in this field, and you really updated us right up to today. We have now some of our colleagues who put up their raise hand sign. We'll go to the questions. Siddesh, your question.
Hello, sir. Good evening. Very nice talk. I just wanted to ask, do you think that B plus R FCR are still out of treatment algorithm CL, particularly in this scenario? And second thing, if we have venetoclax, ibrutinib, acalabrutinib all available over here, what would be your first choice of treatment in India in TP53 mutated or IGHV mutated and mutated class of CLL?
And this is the first question was chemotherapy. Was it FCR you were asking about, the role for FCR?
FCR and B plus R, yeah.
FCR, right? So, sorry, it was a bit difficult to hear, but so the FCR, again, we are not really using FCR. I think if you're a patient who cannot afford a BTK inhibitor, or venetoclax or any targeted therapy, then you're kind of stuck. I think in that case, if a patient is young and IGHV mutated, I guess you could argue to use FCR. If you're going to use FCR, I may consider using only for 3 cycles. If you can check a bone marrow with MRD, if possible, at that time. And if the patient is MRD 0, which most patients will be, I will just do 3 cycles of FCR. We have done some work combining ibrutinib with FCR, actually ibrutinib with FCG, it's FC and obinutuzumab. That data was also presented, updated at ASH. I did not include those slides here. And other people have done ibrutinib FCR. Those data also look quite promising. So I do think that those could be considered, but again, then you're adding ibrutinib anyways, though not for too long, maybe for 12 months. But certainly ibrutinib FCR, ibrutinib FCG look better than standard FCR. Again, I personally would stay away from chemotherapy if you can. For your second question, I think was about TP53 mutated patient in India. I mean, I think the current US practice would be to use a continuous BTK inhibitor. Though we are seeing some nice responses, as I showed you with ibrutinib plus venetoclax, with at least 2 years of therapy. Whether that would last, because we're talking about a relatively small number of patients. So unless there is a larger trial, which longer follow-up, which proves that 2+ years of ibrutinib plus venetoclax is better than continuous BTK inhibitor of 17P, I personally would continue continuous BTK inhibitor for these patients. So for Indian context, if you have a 17P patient, I would just do Acala, single agent, for that patient. Now you can add Acala plus Ven. There is some data. Maybe I would say to wait until ASH meeting to see how Acala plus Ven performs. I think we just need to, because there's no publicly available data with Acala plus Ven at this time, and I think we have to wait for that data before we make any more decision points about using Acala Ven. So I personally would probably use Acala single agent for 17P patient.
Thank you, sir.
Thank you. Before I invite others, what would be the exact contraindication to BTKI with respect to the heart? What kind of heart situation you will say, I will not give?
So, I mean, if you look at the label, there is no absolute contraindication. Anyone can be used. But I think from a clinical standpoint, when you're talking with a patient and I think, oh, it's my family member, what I'm going to do, if a patient in all fairness had a recent MI in the last 1 year, also I get concerned about anticoagulation. I mean, aspirin is okay, but if they're on Eliquis or something for atrial fibrillation, or some other stents or whatever, something else they had, there is a slightly higher risk of bleeding when you're adding with the BTK inhibitor. So I, myself, if a patient can get on venetoclax, I try to do that. Having said that, I have treated lots of patients who are on anticoagulation with BTK inhibitors and they're doing fine. Patients who had AFib, they are doing okay. So I don't think there's an absolute contraindication, and I think we used BTK all the time because previously Ven was not available, like 4 or 5 years ago, because BTK came before Ven. But now that Ven is easily available, I will not think of using it. So Ven is easily available. For those reasons, I would, like, as I said, recent MI, active ongoing AFib, anticoagulation, I may consider using a Ven-based approach, but again, that's my practice.
And similarly, if the kidney is impaired, you can use a couple of months of BTKI and then go to add BCL2.
Yeah, so and that we have done. I mean, I think as I was giving an example, patient comes with very large intra-abdominal mass, creatinine is 2. You don't want to start a Ven on day 1. Just worry about TLS. So why don't you, I mean, you can debulk it, you can, and then, I think BTK is a beautiful debulker you can do for 2-3 months. Now, many times situation becomes in those situations, you can argue that, okay, let's just continue, the BTK patient is already on it, let's just continue it. But yeah, you can use it for debulking and then potentially add venetoclax for that patient as well.
Take one question from the audience. Dr. Shyam has a question. If Pirto moves front line, what will be the future of Ibru and Acala or Zen?
Yeah, I mean, I think so. In all fairness, there is no data reported with Pirto in the front line. I believe the trial which we are going to report at ASCO and EHA will be the first public presentation of a Pirto frontline data. So I guess you'll have to wait for some more time. However, it is true that pirto is in phase 3 studies in frontline setting. So it is very likely, again, depending on how the phase 3s read out, which will be still, a few years down the line, pirto may get approved in the frontline setting. I think, because we are going to use these agents as time-limited approaches, right? So if you're using pirto-Vengi and the trial which we are running now, we've treated about 60 patients now in the last 1 year. So it's a 1 year therapy. You stop at 1 year. No one has progressed in the trial so far. It's too early. I mean, patients will progress eventually down the line when they're not on any of these drugs. And we already know from ibrutinib plus venetoclax, none of these patients at that time will have a resistant mutation. So you can restart pirto at that time, or you can restart ven at that time, or you can restart pirto and ven at that time. So you do a time-limited approach, you stop, you maybe get 4, 5, 6 years out of it, like no treatment. When the patient progresses, you do it again, or you can do just pirto continuous. So I think, it's again it's a new field. I mean, right? No, there is no publicly available data with pirto single agent, pirto in the frontline setting. So we're talking kind of in the future in a way. But yeah, I mean, I think that's what you will have to kind of see, but pirto approval in frontline is still some time away. I mean, the phase 3 studies are ongoing right now.
So with NC-BTKI, it's a time-bound treatment. It's not infinite.
No. So pirto currently the approval is continuous treatment. It's like a BTK inhibitor. However, a lot of development with pirto is happening in a time-limited approach in the frontline setting. So the CLL 18 study, which is I didn't really maybe pay attention, focus on that in the slide I have of different trials. CLL 18, which is a new study from German Cell Study Group, is going to do Vengi as a control arm, pirto-ven doublet, fixed duration, pirto-ven doublet, MRD guided duration. So there is no like continuous pirto. So it's like pirto-ven for 1 year versus pirto-ven for MRD guided. They have some guidance plans for MRD. If you're MRD positive, you can get another year or something like that. So basically what I'm trying to say is that the frontline development of most of the trials with pirto, as is true for most CLL studies, are being done in a time-limited approach as opposed to a continuous pirto. Though continuous pirto is also being in phase 3 study, but a lot of development is in time-limited approach.
Before I take up other question, Dr. Nitin, how much time do you have? You have another lecture you had mentioned.
I have time. I have, and it says my next talk is in 1 hour.
Okay. Khushbu, your question.
Thank you for such an informative lecture, sir. Sir, my question was, I had a 68-year-old gentleman who was a diagnosed case of CML since 10 years. He was in major molecular response and was on imatinib. He had progressive thrombocytopenia and leukocytosis. The peripheral smear showed 90% lymphocytes and smooth cells. We did a flow cytometry and it turned out to be a CLL. So actually that patient was not affording, so we could not do molecular studies on the blood. But sir, because of financial issues and thrombocytopenia, we continued him on imatinib and we gave him chlorambucil and rituximab. And it is 1 year since the treatment. Now the patient is still in major molecular response and his peripheral smear is okay. He's not having any cytopenias. Sir, I wanted to know the ideal approach. How would you treat this patient if there was no financial issue, and if you have any experience on this kind of case, sir, please share.
Yeah, so we had few patients on like this. In fact, one of the patients on the ibrutinib venetoclax trial, if I recall correctly, also developed CML. So we had several patients over the years we have seen with CML. These patients actually had predated CLL and then developed CML, like on top of it, so we have several patients. We have done ibrutinib plus dasatinib, or like basically, double TKI. Obviously, you have to see if the CLL person needs treatment, right? If it's just a dry stage 0 CLL, to say, white count is 15,000, but everything else is okay, you really don't need to treat the CLL part, just treat the CML part. But if the CLL also needs treatment and there are cytopenias of unclear etiology, which could be then CLL related, we have done double TKI, like dasatinib with ibrutinib. I believe we have done dasatinib with acalabrutinib as well. So Or you can, use a Ven-based approach, right? There is data with Ven in CML. Actually, our group had done Ven plus dasatinib, though it was quite myelosuppressive for chronic phase CML. But you could consider those. So I think these drugs could be combined. Again, these are anecdotal cases we're talking about.
Thank you, sir. Thank you.
Thank you. Again, one question. In what percentage of patients you are able to pursue 400 mg of venetoclax for the whole 1 year or whole 2 years?
I would say, so our in the ibrutinib plus venetoclax study, the dose reductions were about 20%. So majority of the patients were able to take it. Now, I would say I've heard this from many colleagues in India or maybe elsewhere as well, that it has been difficult to continue when 400 for these patients. Again, I don't know if there's an issue with metabolism or something in different, patient in Indian population or something, but I think we're able to do it. Now, having said that, I think you go to 400, if a patient develops neutropenia, you go to 300 or 200. I have lots of patients on 150 milligram, lower doses. But generally, I will say for most patients, I'm able to escalate to 400. But as I said, for about 20% of the patients, we'll have to drop the dose to less than 400.
Fahima, your question.
Very crisp talk, sir. Nitin, so I thoroughly enjoyed your talk. I have a question. Like, if a patient presents with CNS presentation in CLL, what would be your first protocol?
For CNS presentation, you're saying?
Yes.
Of CLL?
Yes. I know it's
So-
very rare, but I had
Yeah.
a patient recently. I had started him on ibrutinib because that was the only BTKI that time which had data on CNS penetration. But right now, what is the data and what would be your approach for a patient with CNS involvement in CLL?
So, I would just say, as you kind of mentioned, I mean, these are very rare scenarios, and we have occasionally
Right.
seen them. There are some people who say that CLL never goes to CNS, or I guess maybe older teaching to say in a way that, oh, it never goes to CNS and it's always the Richter's or some other maybe histology which has transformed to. Having said that, I have seen some patients, and again, it's a bit of a hodgepodge. I mean, certainly we have used ibrutinib. I had a patient who had CNS leukemia. He was given high-dose RRC with part B of hypercVet basically at an outside institution before he came to see me. And then his CNS was clear. I put him on ibrutinib. He has been doing fine for a long, long time. So, I think just a BTK inhibitor alone with IT chemotherapy may cut it, but whether you want to use some more intensive chemotherapy, again, I don't think there's a consensus about these kind of things because these are kind of rare things. But as I said, generally, depending on how active the CNS disease is, how much disease is, white count is, maybe there are other, cortical intraparenchymal brain lesions or whatnot. I think if those are the scenario, then maybe, part B of hypercVet, something like that, along with the ibrutinib, and then continue ibrutinib long term. If it just maybe some CNS positive cells, but no leptomeningeal disease on MRI, maybe just intrathecal chemotherapy with ibrutinib may be the way to go. But again,
this is exactly what we did, sir. It was a 65-year-old male with no other comorbidities, headache, CSF flow positive for CLL. But now, luckily, he had no other comorbidities. And now we have acalabrutinib accessible to us. So what do you think of the CNS penetration for acalabrutinib? The data is very non-convincing, actually. So you still would go with the ibrutinib even now? With Zanu and
I personally, I mean, ibrutinib is the most known data for CNS penetration. I personally don't know how much Acala goes into the CSF space per se. I think in this scenario, in this rare exceptional scenario, I would maybe keep with ibrutinib unless we know more about acalabrutinib for CNS lymphomas.
Okay, thank you so much.
All right, good to see you.
Same here.
One question from the audience. Dr. Thanda from Myanmar wants to know, once you use a BTKI and if it has failed, is there any point in just adding a monoclonal antibody, anti-CD20?
So if you're failing ibrutinib and then you just do single agent monoclonal antibody like rituximab or oben, or you add it on top of continuing the BTK and you add it on top, certainly you're going to get some benefit out of it. I mean, I think your disease will stabilize for a short time, but I think it's not probably going to be more than 6 months to 12 months. So yes, I mean, I think if you don't have an immediate access to venetoclax for some reason or something else is going on, I have done that for patients. I have done that for patients who had failed venetoclax, were on Acala, now kind of failing Acala, but I want to wait because we're waiting for a CAR T slot or whatever. So I added Obin, and that seems to have stabilized the disease for the short run, but it's not a long-term strategy. But yeah, I think you can get several months to maybe 6 months out of it by adding some antibody to it.
Thank you. Dr. Nitin.
Good evening, sir. And thank you, Dr. Nitin. And I think some of my questions have already been answered, and in the discussion with Dr. Agarwal also. Only thing which I can think of is the infection part. Do you see increased risk of infections with the BTK inhibitor or combination with venetoclax? Because I have seen few of the fungal infections with BTK inhibitor. Maybe it could be anecdote also. And what is your strategy of using any kind of prophylaxis regard to fungal or viral or PCP kind of things, sir?
So I think the infection, as you obviously well know, depends on the region you are, right? So you guys see much more fungal infections in general, I guess, than what we see here in the US. So, so we don't see, I mean, we occasionally see some fungal infection that has been well associated with ibrutinib. But we have not, the rate is quite low actually. So we don't prophylax with antifungal because first of all, doing voriconazole or posaconazole, you have to adjust the dose and it's just a bit of a mess because these are long-term therapies. So we don't do antifungal. PJP, there is some risk noted, but I think that was mostly in the context of using it in lymphoma patients who are getting also high-dose steroids. So the journal, our data and Ohio State data will suggest there's no need for PJP prophylaxis and we don't use it. And the only prophylaxis we use really is Valtrex, valacyclovir or acyclovir. One could also argue, I think we have just used that because we used to do that for FCR patients for appropriate reasons. And then when ibrutinib came along, we just continued because most of these patients had FCR before. But now these patients are not getting any chemo at all. So, what's the relevance of doing Valtrex prophylaxis? Do we really need Valtrex when patient has not ever had any chemo exposure or fludarabine exposure in the past? And I think that's something we don't know, but our current practice for all of our trials and standard of care is to just do Valtrex single agent prophylaxis. I guess the risk of infection, also the other risk of infection when you're using especially with ibrutinib plus venetoclax is grade 3 or 4 neutropenia, which is about 50%. Generally, the neutropenic fever is about 5%, so it's not that common. So certainly if you see ANC drop, we give a, Neupogen, GCSF basically, and the white count comes up within 2 days because this is not AML patients, right? So, and then you resume ibrutinib and generally at a lower dose. So we don't see that many infection issues per se, but certainly you have to, but it is fungal infections are described, and I think you have to be obviously aware of it when you're treating patients.
Thank you. Dr. Nitin, how effective is ibrutinib for immune-related complication of CLL?
So, I think it does work, but the standard general recommendation will be, if you're talking about immune-related complication in the sense of ITP or autoimmune hemolytic anemia, my standard practice, and I think others the same, is to control the ITP or autoimmune hemolytic anemia with steroids and Rituxan first. And so generally for the first episode, I treat the ITP and autoimmune hemolytic anemia, and that's it. Unless their CLL per se needs treatment for other reasons, I don't start on a BTK inhibitor or anything else. But if they have a recurrent episode of ITP or hemolytic anemia, then I kind of stabilize the condition in a month or so, 6 weeks, and then at that time I start a BTK inhibitor at that time. So first control the disease and then start a BTK inhibitor. Control the immune part of the start a BTK inhibitor. The other rare immune complications, patients could have nephritis, and I had a patient with very bad neuropathy, which was for unclear reason. For that patient, I just started rituximab single agent because I was not entirely sure what's going on, and he just had a 80% improvement of his neuropathy symptoms, within 1 or 2 months, which I didn't really think that would turn out to be the case. whatever the immune phenomena was there, maybe whatever was causing his neuropathy, obviously CD20 antibody has been used for rheumatological condition and, B cell depletion. So, but that his neuropathy significantly improved after rituximab.
Thank you. One more question from the audience. Dr. Kannan wants to know, what percentage of patients who have been put on wait and watch never needed a treatment for even after a long, long follow-up?
So that's a good question. I think I don't know if what actual data has been reported in this regard, but if you look at the studies, I would say there may be around 20% of patients, 10-20% of patients who probably never required treatment. Again, it depends on the age when the patient is being diagnosed. But if you look at the time to next treatment curve from, and I'm just thinking in my mind, at the tail to the curve of several of these studies, I think maybe kind of at 5 to 10 years, at 10 years, it goes down to maybe 15-20% range. Now, there will be some patients who will require treatment in the second year, the second decade. I had recently had a patient who's requiring first-line treatment after 19 years of watch and wait. But those are a rare group of patients. And, obviously, some other medical issue may happen with the patient with such a long follow-up.
Thank you. Dr. Ankit?
Yeah, thank you, sir. Thank you, Dr. Nitin, for that wonderful lecture. My question is in continuation of the last one. So, with the current hope of getting a cure of CLL, when will we start treating all the patients rather than waiting and monitoring those patients? Because some of them many of them will receive treatment ultimately, and some of them will have Richter transformation and they can go into high grade. So are we reaching that point where we start using non-chemotherapy agents for all the patients? Will it be possible, or will it be recommended in near future?
Yeah, so I think this is a challenging question which comes up for discussion quite often within our group as well, where like my chair, Dr. Cantagna, will say, why are we waiting for these patients? Why not we get started and keep moving? And why are we waiting so long? And he had a patient who developed Richter's during this watch and wait, so he was quite upset that we didn't treat that patient early, or he didn't treat that patient early on. I think the data is kind of it's difficult in this regard, because you may know, several trials have been done. More recently was CLL-12 trial, ibrutinib versus placebo, and these were high risk for progression. These were not all comers. These were like high risk, like 17p, all these high risk. But at the end of the day, overall survival was same, and it didn't really see, and the patients got side effects from ibrutinib. Now, venetoclax is a safer drug than ibrutinib. So, and there is an ongoing phase 3 study in the US where patients are getting ven-obinutuzumab upfront versus ven-obinutuzumab when you need them, like 5-6 years, whatever time down the line. And that trial, the primary endpoint is OS, which is fantastic. But I know that trial is accruing very, very slowly. And OS may not read out for, who knows, 5-10 years, 10 years, like it'll be a long time. So I think what we are trying to do at our center is that because the important thing is to identify patients who will progress within the first 1 to 2 years, or who will develop Richters, right? And that's actually a research project we're working right at this minute. We're planning to submit the abstract to ASH, where we're really trying to figure out, and we're really focusing on 17p53 because that's the worst group. Because not all 17p are equal. You can have a 17p patient with mutated IGHV, and they will do well. They will not need treatment soon. So we're trying to look at everything. We're trying to look at FISH abnormality, percentage FISH, VAF of a p53 mutation clone, IGHV status, white count, age. So we're collecting this data. We have about 250 patients or so, something like that. And we're trying to figure out what predicts time to first treatment for 17p, and what predicts for time to treatment within the first 1 to 2 years. And then also what predicts for Richter's transformation. And maybe that will help us identify the highest of the high-risk patients, where you could then say, okay, this is the patient I'm going to use it. Because as you know, ibrutinib, all these drugs, though are safe, they're not like free of side effect, right? If you start a patient on a BTK inhibitor and for early stage disease, when they may not have needed treatment for 10 years and they're up atrial fibrillation, or God forbid, they have a ventricular arrhythmia, then you'll be like, you harm the patient. So that's a tricky part of this situation. So you really have to identify the highest of the high risk. And that's something which which, we and others are trying to look at it now for these patients.
Yeah, so one more question is that regarding the same point. With current CLL IPI score, so is it sufficient, adequate for all newly diagnosed patients to risk stratify, or would you recommend doing anything additional to identify high-risk patients, apart from, say, 17p deletion, high beta-2 microglobulin, and mutated or unmutated IgH?
So we typically do fish panel, which is, fish panel P53 status for mutation, P53 mutation, and then IgHV status. We also do beta-2 microglobulin, but I don't know in the big scheme. I mean, yes, it does add, but, I think it doesn't help me that much in a way. And to be honest with you, we don't really calculate CLL IPI in the clinic. When the fellows are in the clinic, I'm not asking them what a CLL IPI is. I mean, I just want to know if a patient needs treatment or not. I mean, if the rise to 0 CLL, patient doesn't need treatment. And if patient is anemic or thrombocytopenic or is symptomatic or is having big lymph nodes, then they may need treatment. We have to just figure out anemia is not from autoimmune or iron deficiency or something, So I think those IPI, CLL IPI is good for clinical trial enrollment, but in routine clinical practice, it's really not that helpful, right? I mean, you just need to know whether I need to treat this patient or not, To me, CLL treatment criteria are more important because that's one we follow. And if patient has 17p unmutated, then I'm a bit more worried about that patient, and I may see them every 3 months as opposed to every 6 months, But I don't use CLL IPI, to be honest with you, that very much.
Sir, I have one more question, if you can allow.
Sure.
Yeah. So this is related to UK FLAIR study. So when you showed the slide, I was surprised to see that fludarabine and cyclophosphamide were given in oral form. Is there any advantage, or is it just a study designed to make sure that blinding is?
Yeah, so they have been, the UK group has been doing oral fludarabine and oral cyclophosphamide in their previous versions of the trial as well. I think they like it. I know oral fludarabine was available in the US some years ago, but it was withdrawn from the market. I don't think there's anything to say that oral is better than IV. I think that's just their practices. Obviously, it makes life a bit easier if you have oral drug, oral fludarabine, oral cyclophosphamide to do it, So, but, that practice has not caught on. I don't know. I don't know. You guys can tell me if oral fludarabine or oral cyclophosphamide is available in India, but that's what they have been in UK. And their previous trials have also used a similar strategy of FCR, oral fludarabine, oral cyclophosphamide.
Thank you so much.
Used it in past, but I found vomiting as an issue. And then you know what's happening and what has retained, what has come out. Dr. Bharat.
Yeah. Thank you, Dr. Nitin. Wonderful data, very promising data in CLL now with this ibrutinib Acala with venetoclax. But in Indian context, this long-term duration treatment, when patients are not willing or they are not tolerant or have contraindication due to cardiac comorbidity, how do you consider bendamustine rituximab in those particular subset of patients? BR.
Right. I mean, I think if cost is an issue, then that's a problem. I mean, if cost is not an issue, then yes, chemotherapy should not be used. If cost is an issue, cardiac side effects and all those things, I think you have to obviously treat the patient. So I think then BR is quite reasonable, right? If your patient cannot afford ibrutinib or venetoclax or acalabrutinib. But I think the data, as you saw, clearly suggests that I think these novel agents are superior for both PFS and OS. So I think, to me, I think if your patient cannot really afford any of these drugs, then I think we're stuck, and then that scenario, I think chemotherapy is appropriate because you have to treat the patient, right? Now, eventually, I think as we just kind of discussed, I think the field will move away from continuous ibrutinib long-term or continuous acalabrutinib long-term, except for maybe 17p patients. So then I think you could argue that the cost will be less, right? If I'm going to use just 1 or 2 years of 2 drugs, as opposed to 10 years of 1 drug, maybe the cost will be cheaper. Long run, still in the short run, it will be more expensive, but in the long run, it will be. So I think that's what I think could be a could be a factor, right? Because we are not going to use continuous long-term therapy. So the total cost may come down. But still, I mean, I can completely understand many patients cannot afford these drugs.
And my second question is, of course, there are very promising results with this Acala and ibrutinib with venetoclax. And venetoclax dose is the issue or cost. So in India, many physicians of the label, they are playing with the drug interaction or bioavailability. Maybe the we done with abiraterone in prostate cancer. And with this venetoclax, can we combine with grapefruit juice or posaconazole to increase the bioavailability and have cut down the cost? It's a silly question, but
no, it's a fantastic question, and I think this is being done already, because when I talked to some colleagues in India, and I was in India recently as well a month ago, certainly, I mean, we know from data from AML literature where, with voriconazole, 100 milligram is fine. With POSA, 70 milligram is fine. Some people say 50 milligram. POSA is much more stronger CYP3/4 inhibitor. So potentially you could use voriconazole and then use 100 milligram of ibrutinib for CLL patients. Now for AML patient, it makes sense because we have to prophylax them for antifungal prophylaxis. For CLL patient here, you're using POSA or VORI really for cost consideration. They could get some LFT abnormality from POSA or VORI. So, but yeah, I mean, I think if you are running into this kind of situation, I think, I think POSA or VORI is well established the dose. So you can do VORI with 100 of POSA, VORI with 100 of VEN, and that should be fine. Yeah.
thank you.
Thank you. We'll take a question from the audience. It's a simple question. The protocol for stopping ibrutinib before minor and major surgery.
So the standard recommendations for all BTK is minor surgery 3 days before, 3 days after, major surgery 7 days before, 7 days after. It was adopted for ibrutinib studies, and then every BTK inhibitor has continued the same because they don't want to mess up or have some bleeding issue in their trial.
Right. So that's the answer to Dr. Bilal's question. Another simple question is from Dr. Hita. A patient has got deletion 17p or IGHV unmutated. There is no indication to treat. Will you treat?
No, so we were briefly talking about it before. I don't treat right now, but I think this is a question which is coming up for more and more discussion. But I think even among those patients, you can get 2-3 years of treatment-free remission or time to first treatment. So any high risk, unless they meet IWCL treatment criteria, I don't treat irrespective of the genomics of the patient.
Dr. Akanksha, your question.
Yeah, thank you, sir, for the wonderful talk. So I would like to ask you that if we are offering a time-limited therapy to the patient, using these immunotherapy, so what would be your choice? Would it be venetoclax with the BTK inhibitor, or when with the obinutuzumab? So I mean, is there any head-to-head trial, or what would be your preference? I know in US, I think when with the ibrutinib is not approved, but if given a choice, then what should we offer to the patient?
Yeah, so that's a very, very important question. What is the best partner for venetoclax, right? Is it obinutuzumab or is it a BTK inhibitor, and which BTK inhibitor? Yeah. So, so to answer in a simple way, there is no head-to-head trial right now which is reported. There are several head-to-head trials ongoing right now. One will be reported later this year. 2 will be reported at next 2025 ASH. So I think there is some time to know that data. So truly, we don't know which is a better partner for venetoclax. Obviously, when obinutuzumab is the standard approved world over, but I know in India, obinutuzumab is maybe quite expensive and not easy to get. So in that situation, I think, when with a BTK inhibitor becomes a more appealing kind of an option. Now, I personally would stay away from ibrutinib just because of the ibrutinib side effects. We have done a lot of work with ibrutinib, but I think second generation are definitely safer. So then it leaves the choice with Acala venetoclax, or maybe Zanu venetoclax. I know Zanu venetoclax is also not available in India. So now Acala venetoclax, the only problem right now is that we don't have any clinical trial data with Acala venetoclax at this time publicly. There is Acala ven obinutuzumab data, but there is no Acala venetoclax data actually. There are a couple of studies looking at it. they will likely be reported maybe one this year, one next year. So I think, it's a bit of a difficult thing to say. I mean, I think, yes, certainly I would say that, standard would be to do ven obinutuzumab. But again, as I said, for Indian context, the only practical available thing for you guys is maybe BTK ven, So in that scenario, having right now not much data with Acala ven, I may say maybe do ibrutinib ven, as your default agent. Now, if you look at the genomics, if you look at all the BTK ven data, it works across the board actually for all the genomics, So I think you could argue to use it for all patients, but I would consider if you have an option to consider for high-risk patients, especially unmutated patients, I think really works well for unmutated V gene. For deletion 17p53, I think the jury is out there that whether you do that versus a continuous acalabrutinib for your patients. But it's a tough discussion right now because there's some data sets which are not available. I think will be available in the next 6 months, and I think will help us make some of these arguments more clearly.
Thank you. Just for the information of the House, actually, Roche has officially marketing of Oben in India, and they are very attractive PAP program, I would say. They haven't, so for some reason, they haven't popularized it much, so the clinicians are not much aware of it. They have made it quite cost effective. So therefore, I had one question. Should we use Acala with Oben all the time because of those two curves separating so beautifully?
Yeah, so I think it's a good question. So one thing in that study which I didn't show, that 17p group, you would think 17p is the worst group. Okay, I'm going to use Acala alone for 17p, but let's now me add obinutuzumab. Interesting, that group did the same. Acala versus Acala-Oben. 17p did the same. All the benefit was in the non-17p patient for that study. So for the non-17p patients, I think yes, I think if you have Acala-Oben available, in India, I think it would make sense. Obviously, that would add infusion reaction, that would add cost to the thing. I personally have still used Acala single agent even after this data, but the data is in front of you if a patient can afford and they want to get deeper remission. Because one could argue if you're going to do Acala-Oben, why not just do ven-Oben? And if you go all the way, because one of the beauty of Acala single agent is just so easy, So that also becomes a bit of a challenge in terms of the, if you're going to add Oben, let's just do ven-Oben then, But yeah, certainly the data is out there that Acala-Oben is better PFS wise for Acala alone.
Right. Amit, your question.
Yeah, thank you, sir, for that wonderful talk as always. I have a question regarding Richter's transformation. If a patient who has been put on wait and watch for CLL for many, many years now comes to you with a rapidly enlarging lymph nodes, and if you go for PET-CT scan, any cutoff on SUV max where you can say safely rule out that this cannot be Richter's transformation?
Well, nothing is absolute in this world. But as you know, I think most, if it's less than SUV of less than 5, it's unlikely to be Richter's. Some people say 7 as a cutoff, but I think if a patient clinically is very suspicious in a way, what you're describing, rapidly enlarging lymph node, maybe elevated LDH, I'm just worried. If the SUV is 2 or 3 or 4, then maybe not, but I may still try to, if it's an easily accessible area, biopsy it. But if the SUV is anything more than 5 and clinical presentation mirrors kind of Richter's, I would be worried about it. Certainly SUV more than 10, I think it's highly suspicious for Richter's or infection or something else, right? Because infection can also obviously cause rapid lymph node enlargement, and we have seen many times it mimics Richter's. I'm sure you guys have seen as well.
Yes, sir. Another question is, if the patient has developed Richter's transformation developed into DLBCL, any update on the use of polar-based regimen for DLBCL, Richter's transformation?
Not really, so this, Richter's kind of, because it's a rare disease and most of the studies with DLBCLs, exclude Richter's, and the same thing, most of the studies with CLL exclude Richter's. So no practical study is being done for Richter's alone. But anecdotally, we have used for some patients with somewhat limited benefit, not to say it doesn't work, but, I think, yes, I think we have to be more creative about some of these strategy we use for Richter's, and certainly the DLBCL based strategies could be considered as well. But again, not much data is out there as far as I know for Richter's per se with polatuzumab.
Thank you, sir.
Thank you. Dr. Deep?
Thank you, sir, for this wonderful overview. Sir, I have a question regarding a clinical scenario. If a patient of CLL presents with massive splenomegaly and thrombocytopenia, is TP53 unmutated? So what should be the treatment approach in such a scenario? Should we go ahead with BTK inhibitors or should we go ahead with chemoimmunotherapy?
I mean, I would just go with BTK inhibitor. I don't think there's any reason to do chemoimmunotherapy. I mean, BTK inhibitors work very well. I mean, if it's now if you say it's, you know, the platelet count in single digits, something like that, then there will be some potential concern about bleeding risk with using a BTK inhibitor. You know, many times I have used debulking in a way with obinutuzumab and steroids for these patients. So to be honest with you, we generally stay away from chemotherapy these days. We hardly use chemotherapy for debulking as well. Can it be done? I guess you could consider maybe a 1 cycle and then go back to a BTK inhibitor rather than getting 6 cycles of BR to say, right? You can do BR for debulking and then 1 cycle to debulking. And German Cellular Study Group did that. They use many times BR for 1 cycle for debulking. But in our practice, we generally, you know, consider, you know, you can do steroids and then some obinutuzumab and then start a BTK inhibitor. So we don't really make that distinction much to do debulking per se with chemotherapy.
Yes, sir. So I have one more question. Is there any difference in prognosis in patients who just have 17p deletion versus 17p deletion with TP53 mutations?
So that's a you know, there's a conflicting information about this. Some studies have shown that having both is worse than one. Some studies have shown it doesn't matter, even like one or both is the same. It does appear some studies seem to say deletion 17p is more negative prognosticator, like a higher negative prognosticator than TP53 mutation. But again, I don't think we clearly know because some different studies have provided different results.
Thank you, sir.
Thank you, Dr. Deep. Dr. Nitinjan, between this CBTKI, there is a total sort of cross resistance. If you're resistant to one, all are useless.
Yeah, if you're resistant to ibrutinib, acalabrutinib is not going to work. Now, having said that, sometimes what would have happened is the patient is on ibrutinib, develops some side effects, the treating physician stops it, and then they progress. And then, so technically that patient really, if you use acala, likely would work because it was working. And but if you're taking religiously 420 milligram of ibrutinib and you're progressing while on ibrutinib, then acala is not going to work. But sometimes you have to figure out. So sometimes when the patients come in and they say they were on ibrutinib before and they progressed, so I really try to get a history. Were you taking it when the white count went up, or you were off it for side effect and then it went up? Because that could help decide if I want to use acala or not.
The second question is about the vaccinations. Are they effective because of the immunosuppressive effect of CLL? And should we keep giving them randomly to everybody?
Well, so the data suggests that, I mean, in general with CLL, there's less seroconversion, like for vaccine, whether it's COVID or, you know, other vaccines to say, but it's not zero. So, you know, and it's only if you're on concomitant BTK inhibitor or you recently had obinutuzumab, the vaccine response will be even less. But again, still not zero. So, I mean, our practice, we do recommend all patients to get the vaccinations, which are recommended, you know, but realizing that patients with CLL may not derive the most benefit as compared to general population.
So that can happen simultaneously with the treatment with BTKI or BCL2 inhibitors.
I mean, the data, a lot of data was generated in the COVID time, you know, 2-3 years ago when COVID vaccinations, if you're on ibrutinib, the seroconversion rate to vaccine immunity was only like 18-20% when you're on a BTK inhibitor. But as you know, in the general population, it was like 80-90%. So it is less if you're on a BTK inhibitor. There were some studies done in which they tried to stop the BTK inhibitor, then give the COVID vaccine, then wait. But I don't know that you need to do that kind of thing. But people were trying to look at what is the optimal duration of stopping BTK inhibitor, but we never really did that. We just gave the vaccine and continued the BTK inhibitor.
One last question. You touched the subject of BTK degraders.
Just give me one second. Yes, go ahead.
You need to leave?
No. Someone was knocking on my door at this. I'm in the hotel, but I think it's the cleaning lady.
So this BTK degraders, what exactly will be the role in practice as and when they get into?
So that's an evolving field. There are like BiGene, AbbVie, there are like Nurex. There's another company. That 4 different companies have 4 different BTK inhibitor. All are oral drugs. And the phase 1, again, the data is limited. But I showed you just one clinical data, but there are 3 or 4 similar posters at ASH where they had shown like a handful of patients, but it seems to be working. So I think we'll have much more data at this coming ASH. But on the face of it, the concept is you just grab the entire BTK protein and degrade it. So it doesn't matter what mutations are there or whatever. You're not binding to a pocket. You're just degrading the entire protein, which is kind of fantastic. So I think if the data holds true, and again, this ASH will tell, this could be the next big thing. And it could potentially replace the BTK inhibitors, but again, that's maybe far and down. But if they are working well, doesn't matter the resistance mutation, they don't have AFib issues or other BTK side effects that we kind of think about. They are oral drugs, which is big advantage. Then it could be a strong contender to be the BTK, to inhibit BTK by degrading it rather than by using a small molecule inhibitor to inhibit it.
Right. So that could be an independent third molecule.
It could be independent third molecule. I think right now, they are being developed for patients who have failed BTK inhibitor like ibrutinib and acala. But I think if the data continues to look positive, as is true with pirtobrutinib, they will move towards early lines of therapy, and could they become a dominant player in the field of treatment, I think will remains to be seen.
Thank you. No more questions in the chat box, and faculty here, there is no raise hand sign. So I think we have come to an end to this webinar. Dr. Nityan, I'm extremely grateful to you. 2 hours of hardcore CLL, we got educated so much. The patient care will improve drastically. Students must have benefited all across the globe. Even the senior colleagues, a lot of clarity from the talk that you gave. I'm extremely grateful to you. You always obliged us by teaching us, whether in person or through the webs. Great. Have a wonderful day.
Thank you, Dr. Agarwal. Always good at this forum. I enjoy these discussion part and these Q&A. It's very, very, very helpful. So, all right, enjoy. I will head to my next talk. Thank you, guys. Bye. Bye.